Hello, I'm Julie Gayle. I'm going to be discussing cervical cancer screening and prevention. According to the World Health Organization in 2019, cervical cancer was the fourth most common cancer in women worldwide. In the U.S., there's approximately 12,000 new cases each year and 4,000 deaths. The CDC looks at the 5-year relative survival rate, and this is the estimated percentage of cancer patients who will have not died from their cancer diagnosis within 5 years. For cervical cancer in the U.S., it is 67.6%, and we know, of course, if the cancer metastasizes, this will drop sharply to less than 20%. The most recent data reported from the CDC looks at the year 2015, and you can see Louisiana was ranked pretty high among new cases of cervical cancer. There were 236 cases reported in Louisiana, and Louisiana ranked second behind Arkansas in the number of cases. Louisiana ranked fourth in cervical cancer deaths at 3.3 per 100,000 women. So why is it that we're seeing more cervical cancer in the South? Well, this is likely due to the lack of screening. Out of all cancer, cervical cancer is the most amenable to prevention and early detection through screening. Being rarely or never screened is the major contributing factor to most cervical cancer deaths today. So what is cervical cancer? Well, we know that it originates in the cervix, most commonly from squamous cell carcinoma. It's most commonly diagnosed in women older than 30 years of age. Peak age is between 45 and 55, and this is why the current recommendations for cervical cancer screening begins at age 21 and continues until age 65. Hispanics are more adversely affected, with African Americans being second, and it is the most common form of cancer diagnosed in pregnancy. Cervical cancer, as well as CIN or cervical intraepithelial neoplasia, is primarily caused by persistent high-risk human papillomavirus infection, or HPV. There have been, to date, over 150 identified strains of this virus. We refer to the low-risk types as being benign, and then you have your high-risk, which are oncogenic or cancer-causing. Greater than 95% of cervical cancers contain the HPV oncogenic types, most commonly 16, 18, 31, and 45. HPV is a common virus that infects epithelial tissues in both males and females. In addition to cervical cancer, high-risk HPV has been also associated with vaginal, vulvar cancers, penile cancers, oropharyngeal cancers, and anal cancers. It is the most commonly sexually transmitted virus in the U.S., with 14 million new infections each year. Out of those, it's estimated that about 74% of those will occur in people that are 15 to 24 years of age. And it's important to remember that even though the prevalence is high, that these infections typically clear without any treatment, and just keep that in mind when we start going over the recommendations for screening. In considering risk factors for cervical cancer, you want to think about the patient who hadn't had a pap smear in several years. We know that 60 to 80% of women who are diagnosed with cervical cancer have not had any cervical cancer screening within 5 years of their diagnosis. The other risk factors listed here are consistent with persistent high-risk HPV infections, such as early age of intercourse, multiple partners, or even one partner with multiple partners, smoking, immunosuppression such as HIV and high-dose steroid use, if they've had an abnormal pap smear in the past, and then some studies have shown risk factors for cervical cancer include long-term oral contraceptive use and multiparas. In reviewing normal cervical cytology, remember that the cervix is composed of two cell types, the squamous cells and glandular cells. In the endocervix, you can see that there is a single layer of columnar glandular cells. In the endocervix, or the ectocervix, there's the hard squamous cells. And in the endocervical canal, this is basically your transition zone where the glandular cells are transforming into squamous cells. This is significant because this is the area that you want to pap whenever you're performing a pap smear so that you can have an adequate specimen. HPV infection can occur with a break in the epithelium, and the virus can attach to and infect the basal cells. This will typically occur in the cervical transition or transformation zone. Again, that's why it's so important that you, when you do your pap smear, that you actually get this area. HPV infection is usually transient, and this is particularly true in healthy women younger than 30 years of age. About 91% of HPV infections will regress and clear within 1 to 3 years. The median duration for the infection is typically 8 months for high-risk HPV types. Of course, the longer the infection persists, the greater risk of a precancerous lesion. If it even persists further than that, then it can lead to invasion. This is a graphical representation of HPV's role in cervical cancer carcinogenesis. You can see in the first slides, you have a normal cervix, and then the second is an HPV infected cervix. Once the virus regresses, typically a healthy woman will slough off those abnormal cells and reproduce healthy cells in the place of that. Again, if it persists, then you're looking at a development of a high-grade precursor lesion or a precancerous lesion, and ultimately invasion. It's important to note that there's about a 10 to 20 year gap between the actual HPV infection and the development of cancer. And of course, clearance of the virus can occur at any of these stages. And sometimes explaining this to the patient can be a little bit reassuring when they had that first abnormal pap smear. Women with precancerous lesions or early stage disease are often asymptomatic. As the lesion progresses, they may develop signs and symptoms such as abnormal vaginal bleeding, which can be like postcoital bleeding, intermenstrual spotting. They can have vaginal discomfort or discharge, dyspareunia, dysuria. The lesion or tumor typically grows by extending along the squamous and glandular epithelial surfaces and then upward towards the endometrial cavity throughout the vaginal epithelium and lateral to the pelvic wall. In advanced disease, direct invasion of the bladder and rectum can occur, resulting in constipation, hematuria, fistula formation, and urethral obstruction. Distant metastasis most commonly affects the lung, abdominal cavity, liver, and GI tract. Over the last several years, cervical cancer screening has evolved. Goals of cervical cancer screening have included to prevent morbidity and mortality of cervical cancer and to prevent the overzealous management of precursor lesions that will likely regress. In March 2012, the Task Force, American Cancer Society, American Society for Colposcopy and Cervical Pathology, ASCCP, which you'll hear about again, and American Society for Clinical Pathology developed screening and management guidelines for cervical cancer. Whereas we used to perform pap smears on every woman regardless of age, the current recommendations include pap smears beginning at age 21 regardless of onset of sexual activity. Even though women in their teens and early 20s are at high risk for HPV, The incidence of cervical cancer is very low. Routine HPV testing in women under 30 is not recommended. Recommendations include pap smear or cytology every 3 years. Again, even though the prevalence of HPV is high in this group, mild infections will typically be clear without any treatment by the immune system. Women ages 30 and older should be offered high-risk HPV testing in addition to the routine pap smear, as they are more likely to have the persistent HPV infections. Exceptions to these include your immunocompromised. To rationalize the new screening guidelines, the guideline developers recognize that cervical cancer prevention is a process that entails both benefits and potential harms. Potential harms included anxiety from the patient. If they had abnormal pap smear, they immediately feared that they had cervical cancer. They may have experienced anxiety related to a stigma from the diagnosis of HPV or STD. Time and patient expense related to the screening and management, and then pain and injury. There was a time when we were performing lots of colposcopies and they were typically on your younger girls, so there was a lot of unnecessary intervention when if it's a young and healthy female, her immune system will kick in, she'll clear the virus, shed the abnormal cells, and produce normal cells over it. The other, and really the primary method of cervical cancer screening, is done through the pap smear, also called, you'll see it called throughout this lecture and other places, cytology or cytology screen. This started in the 1920s, 1930s, and then over the years, there's been standardized methods of reporting pap smear findings, and we're going to talk about each one of them actually. The Bethesda system is what the system used to report pap smear findings on the pap report, and then when ordering it, you'll indicate the specimen type and source, such as the cervix or endocervix versus a vaginal cuff if they're post-hysterectomy. You may indicate some clinical information, such as if they're having any abnormal uterine bleeding, infection, if they have an IUD present. The second reported thing by the Bethesda system includes the adequacy of the specimen. Is it satisfactory? Meaning, does it include some of those endocervical cells, or cells from that transformation zone that we talked about. And the results will be reported and categorized. It'll either say negative for intraepithelial lesion or malignancy, epithelial cellular abnormality, or other non-neoplastic findings. In addition to reporting the result as negative, sometimes they may identify an organism on cytology, such as trichomonas or fungal infection, bacterial vaginosis. Just remember, you're not going to want to diagnose really off those things off of the pap smear, so you'd probably want to bring them back in to do a wet mount. The second category that's reported is at epithelial cellular abnormalities, and you can see them listed here like ascus, low grade, high grade, and squamous cell carcinoma. Just remember that the PAP's not diagnostic, and so when you look at low grade, it's typically consistent with a mild dysplasia or CIN1, and high grade's typically consistent with moderate to severe dysplasia or CIN2 or above. Again, it's strictly screening, so you would need to do further evaluation. A report of glandular cells, atypical glandular cells, indicates the presence of glandular cells that could be coming from the endocervical or endometrial region. And if they report this, they'll either just say atypical, atypical favor neoplastic, endocervical adenocarcinoma in situ, or adenocarcinoma. The third category can include other non-neoplastic findings, and this could be injury or the body's response to injury. It can be due to inflammation, even atrophic changes. The next few slides include pap smear reports. You'll notice that their findings that they report are consistent with the Bethesda system. It'll include the clinical history that you write on the order requisition, the specimen source, if you did any type of ancillary testing such as gonorrhea and chlamydia off the pap smear. They'll provide you with recommendations like repeat pap smear in 1 year. I would just, make sure that you're following the ASCCP guidelines. The HPV status, you can report it or have it report HPV like as a reflex to an abnormal cytology, or if you're doing the co-testing, which remember can be done every 5 years, which would be your cytology plus an HPV status. Patients and clinicians need to understand that the pap smear is only a screening test. Any abnormal pap smear results should prompt further evaluation with either colposcopy or biopsy. And any patients with any suspicious symptoms or grossly abnormal cervical lesions on physical exam, regardless of pap results, should undergo biopsy. Screening for cervical cancer and the management of abnormal cervical pathology are based on the standards of care put forth by the American Society for Colposcopy and Cervical Pathology, or the ASCCP. They have a free app available for download that includes algorithms for screening and management. The next few slides I'm not going to do audio to. You can just review them on your own, or you can pull it up on the app, but they talk about management as recommended by the ASCCP. Your treatment decisions for abnormal cervical pathology are going to be based on your colposcopy results or your biopsies that you obtain in your colposcopy. A colposcopy allows you to directly visualize the cervix, vagina, and you can even look at the vulva in some cases. You'd want to biopsy any suspicious lesions. If you have a lesion that is extending into or possibly extending into the endocervical canal, you can do an ECC or endocervical sampling. Colposcopy is a primary technique for evaluating any abnormal cytology. For the procedure, the cervix is cleansed and moistened with 3 to 5% acetic acid. And then you visualize that through the colposcope, and any abnormal epithelium should turn white. You can identify capillaries, even apply a green filter to the colposcope to enhance any vascular architecture or look at any atypical vessels. Any of these abnormal areas are going to be targeted for you to biopsy. In order for the colposcopy to be satisfactory, you would need to visualize the entire transformation zone or squamocolumnar junction. As mentioned, you would want to obtain biopsies from any abnormal areas, including leukoplakia, acetowhite epithelium, atypical vessels. There are certain considerations, and if you look on the previous slides for your pregnant girls, remember that if you do have to obtain a biopsy, they're going to have an increased bleeding. To achieve homeostasis after your biopsy, you can apply Moncels or silver nitrate. And of course, if you see the lesion that possibly, or I would do it anyways, do an ECC. This slide just shows where you're visualizing the entire transformation zone. And to note, a Nabothian cyst, this is a benign cyst that's formed when the mucus-secreting columnar cells cover the squamous epithelium, and these are pretty common. This slide shows the colposcopic findings of atypical vessel patterns. This is the mosaicism or punctations. Higher grade lesions are going to have a coarser vessel pattern and a larger capillary distance. While we talked about Pap smears being classified according to the Bethesda system, biopsies that you obtain from your colposcopy are histologically evaluated and graded according to the CIN nomenclature. CIN just refers to pre-invasion or pre-invasive cursor cervical cancer. It is easily detected and treatable. And we kind of already talked about this, but from the point of CIN 1, it can take 10 to 20 years to develop into invasive carcinoma if you never did intervene. CIN divides the epithelial thickness into thirds, so where your CIN 1 might be mild dysplasia, CIN 2 moderate, and then CIN 3 can actually be carcinoma in situ. This slide just shows you how the cells look different at the different levels, and you can see with the carcinoma in situ, like your full thickness lesions are going to have very dilated nuclei. Cervical biopsies are tissue obtained from the transformation zone for a histopathological evaluation. Can also be obtained through laser conization, the cold knife conization, and LEEP procedures. The LEEP, they just use the hot wire loop used to excise a pre-malignant lesion. And remember, this is just like millimeters that it would take, so just a small amount The CO2 laser, this can be used to also treat cervical, vaginal, and vulvar intraepithelial lesions. Cryosurgery has been used too, and that's just where you have, you freeze those abnormal cells and they slough off, and then your hope is they'll produce healthy cells in place. If you suspect that any lesions could be extending into the endometrium, then you would want to make sure you did a good endometrial assessment. You could do this through hysteroscopy, and you can actually see a lot more if there's any polyps, tumors, fungating cancers. You could even do a D&C and send any of that tissue for pathology, and then of course the endometrial biopsy. So once you've diagnosed cervical cancer with histology, pathology, then the cancer is staged, and you can see your early and late stage 1B is still limited to the cervix, whereas once you get into the stage 2B, the cancer is actually spreading and metastasizing outside the cervix into the pelvic tissue. The choice of treatment of cervical cancer depends on the stage of the disease, and of course this decision is made by your gynecologist, oncologist. Treatment can include surgery, even if it's just a biopsy or even a hysterectomy, radiation, chemotherapy, or a combination of those. I wanted to have a few slides on cervical cancer prevention. While cervical cancer is the only type of the HPV cancer for which there's a recommended screening test, we know that HPV causes penile cancer, anal cancer, oropharyngeal, vulvar, and vaginal cancers. And over 90% of these cancers can be prevented through the HPV vaccination. Gardasil is currently the only HPV vaccination available in the U.S. It was approved in 2014 by the FDA, first a bivalent, meaning it covered 2 strains, quadrivalent, and now a 9-valent. Since late 2016, the only 9-valent is the Gardasil, and it protects against 9 HPV strains, including 7 that cause cancer. Of the 32,500 cancers that HPV causes each year, it's estimated that 30,000 can be prevented by the 9-valent Gardasil vaccine. The CDC currently recommends the HPV vaccine in adolescents as early as 9 years of age. It is a series of 3 IM injections over a 6-month period. A 2-dose regimen is currently recommended for children younger than 11 years of age. Ideally, people should be vaccinated before they begin having sex, so before they're exposed to HPV. However, people who have already been infected with 1 or more HPV strains, they can still get protection from the other HPV strains. Know that it does not treat an existing infection or eliminate the need for cervical cancer screening. Research shows that the benefits of the HPV vaccine far outweigh any potential risks of side effects. Like any vaccine or medicine, the HPV vaccine can also have side effects. Some include a mild pain, redness, and swelling at the site of injection, dizziness, fainting, nausea, and headache. The HPV vaccine can be given safely to people with minor acute illnesses, with or without fever, women who have had an abnormal pap smear or in the middle of managing an abnormal pap smear, immunocompromised, and women who are breastfeeding. The HPV vaccine should not be given to people who are allergic to any components of the vaccine, any immediate hypersensitivity to yeast, and of course if they have a moderate or severe acute illness, it can wait until they've improved. Although there's been no adverse pregnancy outcomes or adverse events for the mother or fetus, it's currently not recommended in pregnancy. Further testing is needed. This wraps up the lecture for cervical cancer prevention and screening. The next few slides just have resources for you as the provider and for your patients. Thank you for listening.